The data that I'm going to present, I'm basically just going to talk about some preliminary data just from one project that's currently underway. And this data is all from Dr. Trisassi Lestari, otherwise known as Sassy, who some of you will have met last year at this meeting. She's super busy doing this project, and she's also just been in Darwin the last couple of weeks and lots of travel, so she wasn't able to come to this meeting this time. But this is basically all her work. There's a lot of people involved in the work. I've shown in this picture up the top, it's a bunch of us in Indonesia, and then down the bottom it was a group that got together in Malaysia. You can see Steve included in there. This was and then we've got some of our Indonesian collaborators there who came over to the meeting in Malaysia. So this is a study which has an arm in Indonesia and an arm in Malaysia, but I'm just going to be talking about the Indonesian side of it today. It's a collaboration between Gajah Mada, the local health NGO in Indonesian Papua province. This is the Malaysian counterparts, Burnett and Menzies. And this is where the study is located, in Timika, which is a really fascinating place to have the opportunity to work, right near Freeport Mine. It's a population in a state of flux, a lot of growth there. This is a study that is happening. It's a health system strengthening project. It's very much implementation research. And what I'm going to be talking about today is really how the implementation is rolling out so far. And there's 5 sites involved that you can see. 3 primary healthcare centres, or puskesmas as they're known in Indonesia. One of them is a fairly remote site. This one here, it's a good. It's about 20 kilometres away, which it does take a little while to get to, there's a lot of river systems around there. Often patients are quite isolated, and getting to them involves going by boat. 2 of the sites are also hospitals, so the Papuan Community Hospital and the District Hospital as well. And the estimated TB incidence in this area is reported at 468 per 100,000, but it's very clear to everybody who works there that the case notification rate is too low, and there's probably many more cases than that. So the aim of this study is to strengthen the implementation of TB contact investigation and management. Obviously there are WHO guidelines around this. There have been local guidelines in place for ages which just basically haven't been implemented, which is a pretty common experience, I think, across a lot of high burden countries. So really this project is just about how do you bridge the policy practice gap. And in doing so, how do you also find those other cases of active TB that might be there in the household as well? We're starting at these 5 sites, but with very clear plans to upscale. I don't think you need to go through that graphic because you know how it all works. So this is a prospective study to evaluate the effect of a multi-component intervention at these selected health centres in Timika over a couple of years. And it uses mixed qualitative and quantitative measures and implementation research frameworks. And I'm not actually going to dwell on the methods much other than this slide. And I'm also not really going to report on any qualitative results. But luckily we can use a long retrospective baseline period of data in terms of what has been happening in terms of contact investigation and management, and what that shows is that really, apart from a very tiny handful of cases, nobody was really getting isoniazid preventive therapy. And part of the reason for that is because one of the barriers that was identified very early on in the study, actually it shows it here, is that there actually wasn't isoniazid available at a child-friendly dose of the 100 milligram tablets. It just wasn't available in the province at all. So that was one of many barriers. So I'm just going to talk through now about some of the implementation activities which have been put in place so far, driven very much by Sassy and her colleagues in Indonesia. So the first one obviously has been about building partnerships. So Menzies has had a collaboration with organisations in Timika for many years. It's where I was based for my PhD a long time ago. Reinvigorating those linkages and making sure that all the relevant people are involved. This is a picture of Rini Paspaprojo, one of our local investigators, and some other local key stakeholders signing some partnership papers. Sorry. There's been a lot of training going on as part of the project. And the training is wider than just the 5 sites. So people providing TB care at a number of Puskesmas in Timika have been invited to these training days. The first one, there was some data collected on people's baseline TB knowledge and also readiness to change, and a lot of education provided about the local policy and how to go about implementing it. And then there was a second training day, which was a practical skills workshop on how to collect induced sputum specimens and that sort of thing. And these were Dr. Rini Triasi, who some of you will know, helped run these workshops, and they were very well received. So, as I mentioned before, actually getting hold of the isoniazid, that was could have been seen as a massive stumbling block, but SASI's really effective at communicating with all the right people, and it involved lots of official letters, and eventually the tablets materialised and were able to be distributed. A social media support group's been set up on WhatsApp that's moderated by SASI with some help from Rena as needs be if there's complex clinical questions that come up. And that's a very popular forum and very helpful to support local healthcare providers. A lot of the healthcare providers doing contact investigation and management and commencing people on isoniazid preventive therapy are nurses, especially that more remote site that I mentioned is nursing run, and there are a lot of clinical questions that come up and a lot of guidance that's needed. So having this sort of support and regular face-to-face meetings is a really integral part of rolling out the policy. There's also been sort of ramping up of the outreach services being provided. So if you ask, the Puskesmas head, do you do outreach? They'll always say yes, but when you look into it in more detail, in fact, it's not. People are tending to stay in the clinics and not actually getting out. And when they do go out, they forget to take the sputum pots with them, or whatever forms are required. So doing that in a more structured way and supporting that process has also been part of the study. The Indonesian guideline was in a form that was a little bit hard to read and difficult to disseminate, so SASI sort of reformatted, fixed some errors, got it all approved by the NTP and redistributed it in Timika, and also developed an educational brochure for patients, and is currently in the process of working on a video to provide some patient testimonies to help encourage parents to treat their perfectly well child, for 6 months with isoniazid to demonstrate, the potential outcomes if you don't. And a key sort of pillar on which the methods of this study are based is the notion of continuous quality improvement cycles, where people proactively engage with their own clinic data and have it presented back to them in a sort of face-to-face forum. So this is one of those CQI workshops in action. That's SASI there sort of handing out some printed materials showing how individual clinics and overall they're tracking towards key performance indicators in terms of numbers of contacts screened and numbers put on therapy. And it's interesting to do this sort of thing in this environment compared to doing it in the Northern Territory, where I've been involved in this sort of work as well with Aboriginal community clinics. They seem very, very happy to share data and not so worried about keeping their clinic's data confidential, and they really like competing with each other in terms of seeing who can reach the highest KPI level. So I've only got a few months of data to show here, but you can see that at baseline in terms of contact screen per month, the proportion eligible for IPT and commencing on IPT, really there wasn't anything happening apart from maybe one patient that got some treatment started on treatment in July. The study activities commenced in September with the training workshops that I described, and then the isoniazid was also delivered to sites, and this started the increase in screening and going on to therapy. You can see there, and that progressed on. There was a CQI workshop. For some reason things dipped there, and then did dip further over Christmas. So Papua is quite a Christian province of Indonesia, so things do close down until over Christmas, but then started to pick up again as the project picked up, and it looks as though there are upward trends continuing, which is nice. If you look at, this is actually, so that was the study data that we're collecting actively. This is now looking at the District Health Office reporting, including some other sites. And this is the cumulative case numbers commencing isoniazid preventive therapy. This is April last year, sort of coming through to March of this year. And you can see that the cumulative numbers are going up very nicely. We can see this, that sites that are not actually participating in our study are also, there's change occurring there. And this is the problem with implementation research. Is this something that just would have happened anyway without our project? Or is this a spillover effect of the activities that are being undertaken as a direct result of the study? And obviously we'd like to think it's the latter. And there's a few reasons to think that that is definitely the case. But this is especially where the qualitative data will help to answer the questions of, why are people changing practice? So just to have a look at some processes site by site. So this is one of the central primary healthcare centres, and you can see that they're not doing too badly in terms of the proportion of all cases in which contact tracing is occurring. It would be nice if the orange line was completely overlapping the blue line, but it's not. But anyway, at least it's tracking in parallel, sort of. This remote site here, which is the really small one, which is totally run by nurses, is doing the best. So of all the cases of TB that they're diagnosing, really almost all of them are getting contact investigation happening. But unfortunately this isn't happening at the hospitals. The two hospital sites, there's this big gap where basically for patients who are diagnosed with TB, contact investigation is not occurring. So recognising this problem, the reason for that simply is because they don't have the structure to do it. They've got smear diagnostic facilities, they've got doctors there to stick people on treatment, but they don't have a link to a public health service which can then go and do house visits or have a process for doing the contact tracing and supporting that individual's adherence. If they default, they don't have a mechanism to go to the person's house and get them back again, which the primary healthcare centres do. So as a result of that, there's been a recommendation of a change which was endorsed by the local district health authority, which is to advise hospitals basically to refer their newly diagnosed TB patients to the primary healthcare facilities rather than holding onto them and treating them themselves. And that sort of thing, it raised some alarm bells with me, because one of the main barriers is cost of transport. And if you've paid for your transport to go to the hospital and then you're being told actually now you've got to go to somewhere else, it just adds to the burden for the individual trying to access care. But the feeling on the ground is that this is a much better process, that the individual will then thereafter go to their primary care clinic, which is often a lot closer to their home anyway than the hospital was. But individuals who are sick don't know that. They don't know what's wrong with them. They trust the hospital, so they go to the hospital. And again, the qualitative data collection around both staff and patient experience will be helpful in understanding what's the best way to deliver care to people. But anyway, if you go back to this plot, you can see that since that policy brief was released, in fact, it has had an impact in that now there haven't been a whole lot of new cases being held onto by this hospital. They're referring them out to the community clinics, which is good. So that's the end. Thank you.
Thanks very much, Anna. So I'd like to ask Justin and Philip to come down if you'd like, and then I open the questions. Justin, do you mind, and Philip coming down? Nice range of presentations, I think. Yeah. Philip.
Justin, I just wanted to ask you what your thoughts are on the reinfection potential, given that so many of these people are travelling to.
Yeah, look, I think there's a number of things to be said to that. I guess in the first instance, if we start by saying that, just broadly speaking, people do travel, there is some potential for reinfection. Reinfection is obviously going to blunt the sort of idealised effectiveness of any kind of test and treat strategy. My own feeling is that that's going to be a relatively limited effect, actually, and I think we've got a number of different things to support that. I think that some of the data that actually, Philip, you were sort of gesturing towards around some of the protective effectiveness of BCG, or some of the persisting effectiveness of BCG, I think is also mirrored in some of the ways that people have tried to look at risk of reinfection and progression to active disease after a first course of disease, which comes up with quite similar numbers, sort of suggesting something between 50 and 80% effectiveness against that. Clearly this can be overcome, and we're all familiar with very high intensity settings where people are regularly re-exposed and reinfection is going to be common. But I think the data that we've got from travellers from low incidence settings suggests that actually it's going to be a relatively infrequent event. So I think we've got a lot of work to do about quantifying that, but my big picture sense is that it's going to be an issue but not a make or break issue.
Ben.
I want to ask Phil, it's fascinating about the consistency of your data on BCG protection against TB infection, but whether you think you have this unique access point to students in training where you seem to be able to recruit hundreds on a day. We have internationally moved from potential multiple BCG vaccinations to a single at-birth vaccination. But is there any potential to re-explore what's the value of an adolescent, or let's say a medical or nursing training entry vaccination, looking at disease risk, immune profile, whether you can blunt the waning. Obviously we're waiting on new vaccines, but until we have the new vaccines, you seem to have a good cohort to look at BCG revaccination as a...
Yeah, I think the advantage of healthcare workers and students especially is that you're getting them before they're exposed. And that there are issues around, and I didn't mention the other body of work about improving the system so they're not exposed, which is a moral and ethical obligation on being involved in that type of work. I keep forgetting to reread that Brazilian paper which repeated BCG and found no benefit. And I think that was at young adolescents.
Yeah, single high school paper, and that changed global policy.
That didn't look at infection, it looked at protection against infection.
Protection against disease.
Yeah.
But I mean, it may be that, and infection will be involved in that, obviously.
Sure.
It may be that you need to give a repeat BCG vaccine later, or something like that. So it's still on the table and under discussion. I think we just need to go make sure that we have all the information from background studies really clear before we start proposing repeat BCG in anyone. But it's something we're thinking about, and especially thinking about those who haven't been BCG vaccinated going into a situation like that. A pretty strong indication, I would have thought, to give them BCG, especially if it's their first one. And I'm not sure, I think the proportion is, it's not 0% who have not been vaccinated. There's certainly a small, reasonable minority.
Jamie?
Question, Phil. So something you alluded to at the beginning of your talk was distinguishing between those individuals who are not exposed but never get infected, or individuals who are never exposed. Because obviously those individuals who completely clear the infection very quickly will be quite interesting to know why they do it at the level of immune response. So is there any way of identifying those individuals?
So those are the people who are not exposed versus those who are exposed and have cleared.
And have cleared,
So that boundary, yeah.
and therefore have no signs of infection at all.
Yeah, so that's what I was hinting at with the monocyte signal that we're picking up. That and so that's suggesting that at least a subgroup of these persistent negatives are resolving an inflammatory monocyte-driven response that's clearing the buck. That's what we're taking from that. And if that's the case, or we can characterise that particular immune response and pick up more signals from it and really nail it down, that would be the obvious one to distinguish those two groups of people. Yeah.
Anna?
So I mentioned the BCG scar as well, because you're using scar as a surrogate of vaccination, right? And I actually wonder whether it's not a surrogate, but it's actually a marker of the response to the vaccination. And those with a very large scar actually think about being protected, right? Because you have a really strong immune response, and could be monocytes put it to the response. You look at the size of the scar, for example, as a measure of the actual innate response.
Yeah, we've looked at size of scar in the Gambian studies, the immunology collaborators, and never found a relationship of any type with the immune response. Others may have. I don't claim to know all the literature on it. And I understand the issue of the fact that we could be introducing a bias by people vaccinated and not mounting an inflammatory response, and that reflecting in their ability to be infected or not infected on exposure. It's very difficult to correlate, to get records of their BCG vaccine dosing. My intuition from small amount of understanding of studies that have looked at that would suggest that well over 90% of the time you will get a scar forming. But happy to hear other opinions or data on that. I think it's made probably less of an issue than it's not enough of an issue to negate the basic message, I think, in terms of such a strong BCG protective effect, that we might be biased by people just not making a scar who actually were vaccinated.
Yep. I'm sorry.
It was just, does it matter which vaccine you got? So of my 3 children, I have one who got the Polish vaccine because of the worldwide shortage, and that one child doesn't have a scar.
Yes, I understand it does. I'm not an expert on that.
Certainly there's some evidence to show that strain's probably important in terms of immunogenicity response.
So, Justin, with all the different options you put up for programmatic ways forward, has that all been have there been much in the way of health economic analyses of the different ways that this could unfold in Australia? Because it seems like there are such a wide range of different delivery models and outcome models and
yeah, I mean that's I guess at the core of what Katie Dale's PhD is sort of focused on. So I guess what I've presented is some preliminary work that kind of provides some groundwork, but what she's really wanting to use that for is into health economic evaluation. So that's the work that she's doing just at the moment.
But are there being models set up of different? I mean, are there different models being set up of delivery to sort of provide the uptake and costing and yield data that will inform those analyses in a systematic way?
I guess I might be missing the...
Well, I guess for a health economic analysis, you're going to need a lot of information on what the uptake is, what the yield is for the different screening situations, and I mean, are we collecting that on a systematic basis in Australia for a number of different for these screening programs?
Look, I think yes and no. I think there are lots of different models currently employed, and so we've got lots of points of data that come in from those different models and how they're done. That's not by way of what I'd kind of love to see happen, which is a Bayesian adaptive trial specifically around different models of latent TB care, where you sort of zero in on some of these questions as time goes on. So I think we've got lots of data to inform those models, but there's certainly also a need for a lot of primary studies to keep making them better and better.
Yeah, Catherine, Amrita, Catherine, what did you do? No.
I checked mine.
Okay. What, Warwick?
So two questions. One is the impact of BCG you were showing in the study was against a single episode of infection. And in fact, one could envisage that actually might be boosting the immune response and then have a subsequent effect. But you don't know that it's going to be the same in each effect, in each episode. So what is the quantitative or cumulative exposure which would be reflected by this protection of the long term? And for that to understand, and this is really the question, is I think traditionally annual rates of infection were determined in primary school aged children as using tuberculous skin tests. Is anyone looking at measuring rates of infection in population using IGRA? I mean, it would be a large kind of study to try and estimate what are, say, annual rates of infection in Bandung. Do you have any idea of what that is. And from that you could extrapolate possibly what was the cumulative effect of the BCG against infection.
It's quite a good question for a
Good question, yeah.
It is. Alison Ryan.
She's already said she wouldn't answer that.
Answering the question.
We might have the opportunity
Guy.
to do that, yeah.
I think studies like yours and the Chinese, I think that have been publishing recently on large scale.
I'm aware that I think Alison Grant's group in South Africa is trying to do something like that on a population scale I think it's in central South Africa somewhere.
There are probably less annual risk of infection studies than there used to be because it's been debunked as a tool for measuring case detection rates.
Yeah. Prevalent studies have taken that.
Just the other thing is that the Department of 12, the Department of Homeland, whatever it is, has started doing that for the last couple of years as well, and it's sort of a bit dirty data, but we do have testing for latent infection in 2 to 11-year-olds now.
So we'll have a 1-year follow-up from the medical and nursing students in that setting. But it's very different, obviously, from the community.
That would be really interesting to compare the data for younger kids, though, to see what happens when people start attending university, and especially when they start working in healthcare settings. To have that data for young adults is actually really valuable.
Yeah. Amrita, sorry?
Yes, just a question for Justin. I was just wondering where you saw the role for diagnosis and treatment of latent TB in Indigenous Australia.
Yeah, look, I mean, I think, first of all, it's always important to ask these questions in terms of what are genuine risk profiles. So we want to think about rates of active disease across the country. I myself am based in Victoria, which is a low Indigenous population, and so don't have a lot of experience working directly with programs around issues of feasibility and acceptability and so forth, but certainly there's some signal around risk, and there's a lot of work that I'm aware of in the Northern Territories that involves community-based testing and treatment. I don't know if, Anna, you want to comment on that? Or
just to say that screening and treatment is still based on household contacts and community contacts of a case. So, using a concentric ring type approach. So if there's a lot of positives in the immediate contacts, then you spread the net wider and wider, which can end up involving whole communities, because a lot of Aboriginal communities are quite small, 300 to 600 sort of people. But I mean, the big issue that we have is renal transplant. So many people have got end-stage renal failure, either on dialysis or heading for transplant, and so that forms a large group of who's been tested and treated among the Indigenous population. But it's not widespread across the entire population.
Catherine, just last 2 questions. Yeah, Catherine and then Emma.
Just when we do expand IGRA, I don't know exactly I don't know whether it's on the MBS at all. I remember mine being expensive. So when you expand testing with IGRA, are you shifting that cost onto patients, or are there people for whom that's covered under the MBS?
Yeah, so, I mean, look, obviously the healthcare system being state by state, there may be some slightly different answers there, but the Medicare indications for IGRA testing have expanded a lot in the last couple of years. So from a situation about 18 months ago where it was listed just for immunosuppression, there is now a broader indication which includes people with a history of TB exposure. So there is a much larger group of people who I think are epidemiologically appropriate to test for latent disease who are also covered for MBS reimbursement, but context will have to work out. We pay for quite a lot of IGRAs as well for certain populations, so yeah, there'll be a case-by-case thing, I guess, for different jurisdictions.
Emma,
I was just giving the perspective for the Queensland, the Torres Strait Islander and Indigenous people in the north of Queensland. Similar to what Anna's saying, it's still contact tracing based, but we have expanded to as many as like whole schools and things like that. And when there's a known case, that's kind of really widely accepted, but we've found it. But to try and do it at scale when there's no kind of motivating risk or exposure is really hard work in communities we're talking about. Just doesn't get accepted. We can't even get people to come to a meeting to talk about TB, let alone to come and have blood tests taken and things like that. So I think we're going to face some challenges.
Great. Well, it's been an excellent session, and thanks to the three speakers.